basically clinical BPH, um, uh, what we are addressing today has a three component. One is a benign enlarged prostate, lower urinary tract symptoms, and obstruction. And the prostatic obstruction has to be differentiated from the other causes, which could be neurogenic bladder, sensory defect, detrusor instability, detrusor underactivity, which is giving rise to the lower urinary tract symptoms. Now, of course, we got to rule out the do the PSA to rule out malignancy, as early cases don't have any symptoms. So enlargement can be done, assessed by the digital rectal examination or a transrectal sonography. LUTS, we can do IPS score. And obstruction, best way to do a uroflow and look at the residual urine. You know, and I'm not advancing. Okay, so now in the uroflow, you can see this is normal flow, and this is probably a stricture, and this is the obstructed flow. And what is most important for all of us today is when we are talking about the technique, the assessment of the prostate size. And there are many ways we have been doing. Initially, we were doing digital rectal examination and grading the prostate as a grade 1, grade 2, grade 3, and grade 4, depending upon how much is the bulge. And it's a subjective assessment. Then we did a cystoscopic evaluation. How does the prostate look? Is it concave? Grade 1 is a little bulging inward, but do not touch in midline. Grade 2 is touch in the midline. Grade 3 is the lateral lobe touching and midline 2 to 3 centimeter, and like that, you know. And then came the cystoscopic measurement of the length. As prostate enlarges, there is a stretching of the prostatic urethra, and then you judge how much is the enlargement by judging the length of the urethra. And of course, what is more dear to me is ultrasound, because digital rectal doesn't allow you to assess the median lobe. And here the Katie Fu, he very nicely categorized the median enlargement. If it is less than 5 millimeter or a 0.5 millimeter, there's hardly any symptom. For 1 millimeter or 1 to 2 millimeter or more than 2 centimeter, that would have the symptoms, and you have to consider in your operative field. As far as the ultrasound is concerned, ultrasound can see the development of the prostate all through the age. But once the prostate increases in size, the transitional zone, it starts occupying the whole prostate and pushes the peripheral zone this thing, and you can measure the prostate. Once you have a symptoms, and once you have a large gland, which is, say, transitional zone is more than half the size of the prostate, or a picar, which is very near to the 0.75, you know it is the obstructive gland. So I feel the volume determination before doing any type of prostatic surgery is important, because it correlation with the resection weight. You know that he is going to get better. You can anticipate blood loss. Previously, in the beginning, we used to say 1 gram for 10 ml for 1 gram resection. But now, of course, it has come down because of the improvement in the cautery and the diathermy, and then how much time is going to take. Not all the investigations are necessary in the individual case. Now, this patient, mostly we all do in the spinal anesthesia, and we use resectoscope, which is available from 22 to 28. For Indian situation, we feel that 24 and 25 is ideal. Otherwise, if you go to 28, chances of getting a stricture formation is very much more. Initially, we were using a standard loop with a monopolar cautery and for the average size. But then as the technology advances, we started a Wage loop, which was quite good in resecting and controlling the hemostasis. But today, the bipolar loops is the most common we use, which reduces the TURP syndrome, no charring of the tissue, good, and the high power current generated does not dissipate. So it gives you the better picture. And previously we were using water, but now we are using saline. So we see a less amount of TURP syndrome. Now, question is, before we start, do we do any dilatation? I always do a dilatation. First, I look at the meatus. If meatus is small, I do a dorsal mearotomy. That will avoid the stricture of the meatal. Then I put lots of jelly and then examine the through the scope, which is a 19 or 18 or 19 French, and then look at the urethra, and then I dilate the urethra up to 26 or 28. That has reduced significantly the stricture of the thing. And intermittently I put jelly so that there is no hot spot on the urethra, so the stricture formation is not there. And at the end of the surgery, I do a bladder neck incision so that that stenosis part reduces. Previously, we used to have about 7% stricture formation. Now with this measure, it is dropped less than 2%. Now this gentleman is 59 years. He's got an IPS score of 19, and this is the prostate. Now prostate is about 47 grams and the transitional zone is 42. So BPH is a very large, and you can measure the amount of BPH. Important is if you measure, and when you know that suppose this is about 14 or 15 millimeter, and then each cut would be 1 millimeter. So I will need a 15 cut before I reach a capsule. So that sort of idea in the mind should be there. And then my technique usually is ventral. Ventral means 12 o'clock first. And then because I reach there and then I go. But sometimes if you have a large median lobe, then you have to do the floor first to make sure that the median lobe goes away and you can have a good flow. And then one lobe after another, that is a teaching purpose. When we do one lobe and then we give the one lobe to the resident, and he sees the thing and he do it and you can observe him. So here is my technique. Now here, the basic of my technique is I start from the 12 o'clock because the blood vessels comes here at 1 o'clock or 11 o'clock. And here I cut off the blood vessels. So the most of the prostate becomes a little less vascular. Of course, venous will be there. And then I go from 12 around the capsule up to 3 o'clock or up to 9 o'clock and drop the prostate into the floor and then do it. The first, I do the examination, and you can see this is a veru and there's a bulging gland. It is a large gland, 42 grams. And here you can see that urethra. How long is the urethra? There is no much of a median lobe. But then I look at the ureteric opening. Where is the ureteric opening? And then, so then I can start my resection properly. But here is a large gland. So I put a suprapubic trocar. So it becomes a low pressure TURP. So two advantage, it will keep the pressure down. The bladder remains empty. So less chance of absorption except, and then I keep the irrigation at 45 centimeter, and so that the direct flow would not be absorbed much. And then second thing is the flow is from the resectoscope goes into the bladder. So the all fluid and the tissue goes out, the bleeding also go out. So you can have a good vision. So this is how you do. So this is the prostate. This is at 12 o'clock. Now here I take it because there is hardly any tissue at 12 o'clock and you would reach the capsule very quickly. Once you know the capsule, you know your plane, where you are going. And then once from there, I go along that exposing the capsule to up to 3 o'clock. So I will start doing this, resecting it. There will be blood. This is the blood vessel which I was talking about. They all enter at about 12 to 1 o'clock. And then I go on doing it. So now you can see that bleeding. We can stop it. So the most of the tissue afterward become less vascular. And here, this is a bipolar. And here you can see that the vision is very clear. And you are resecting and then doing. One of the most important thing, how you hold your resectoscope. You hold with the left hand who hold the penis, and with the right hand you use a resectoscope. So you can whenever you here now, moment you engage the tissue, you can put a little pressure in the tissue so it can go in. Then while you are coming out, you bring it out. So with the hand movement, you can adjust how much tissue you want to remove. Now this is the one lobe is dropped. Now I'm going to the other lobe, and here is you can see the bleeding, and that's the blood vessel I want to stop. Now remember one thing, this is the where if you have a severe bleeding post-operatively, usually you go and look for this spot, because from there you can have a large bleeding point if it is not controlled properly in the early phase. In early phase, we had a spark wall type of diathermy. Then the solid state came. So, so that has much more improved the complication rate of bleeding. So, and then of course this, you can see that the bipolar also is If you do it very slowly, you would be aware. So once you have dropped both the lobes on the floor, then you go to the floor, make sure that all the bleeding on the sides are controlled, and then you start resecting the lobe which is in the floor. Now this is a very comfortable position where you can hold nicely with your left hand the penis and the resectoscope, and then dig out and then scoop out the tissue. And then you start from the little inside the bladder neck, and then just before the apex or veru, you come back and come forward. So you get a nice chip. Now, moment the chips comes with the flow, the chips the fly off into the bladder. So your vision remains clear. So and then at the same time, you can look at the suprapubic flow of the irrigation. So you will know how much is the blood loss. Anesthetist will know how is the bleeding is happening. And whenever this happens, is about in 15-20 minutes time, you do look at the pulse rate of the patient, because all the patients are monitored. When you find there is a little bradycardia, you ask the patient anesthetist to give a Lasix. Anyway, whenever such a large gland is there, after 15-20 minutes, I always ask the anesthetist to give a diuretic. Now here the whole gland is on the floor, and you can see that is almost there is not much of a bleeding, and if there is the arterial blood, you can always coagulate with a pinpoint, and then you can resect out. You can increase your speed as you are resecting the maximum number of tissue, and then you can see this. Now, most important is when you resect, don't resect at the same place. Go to the next place, because what happens that after resection, you go to next place, and then come back to the original. The prostate is pushed out. It's propped out because the fibrous covering is gone. So it is easy to resect the prostate, which is like here. You can see that the prostate is bulging into the lumen now. Initially, it was quite well packed. Now it is this tissue which was I resected. Now it is again come out in the remaining tissue is pushed out. Then you can cut it. So don't cut at the same time, same place. Then go on changing a little bit, 1 millimeter, 2 millimeter away, and then go on like a viper, and then go to the other place. Now here the floor is resected. Then you come to, when you see this, the apical part of the prostate will be pushed out, and then it will be easy to dig it and then come out. But making sure that you don't go behind the veru. And that's how your hand is very important in holding the penis as well as the instrument, so that you have a control over the instrument. You see the tissue, you dig in, take it out, and go forward. So so you don't go backward, so you don't damage the apical part or the sphincter part. Sphincter has 3 places near the verus, superficially, then from veru till urethra, and then outside the urethra. So you must make sure that this area is well respected. Now this is the prostate which is bulging down, and then you must go back, because you might have an impression that you are taken out completely, but suddenly when you go and see, some prostate is dropping down, because this, if it is left behind, will be responsible for symptoms of frequency, sometimes patient irritation, and for some time. So always make sure that I'll go back and see, and then when you moving around, you will be able to see that the prostate which is bulging, you can take it out, and then you have counted what is the length of that lobe, and then you know that about 15-20 cuts you will be near the capsule. Now you don't want to go near the capsule, because you are likely to perforate, or you can perforate the venous sinus, and you can have a torrential bleeding and infection. So what I do, I leave about 2 or 3 cuts before the capsule which I'm expecting, and at some places I expose the capsule, then I know I'm very near to the capsule. Then I'll go to the different places and take out something which is bulging, but I will not expose the capsule completely. At some places here you can see that capsule is seen, so I just wait there, and then now here the capsule is there, so don't just cauterize it. Then the apical part is there, and so then come to the floor, and then make sure that whatever is, bulge which is come back, which you divide, but remain in about a millimeter or so in front of the veru. So um, so you will not damage the veru or ejectable duct. That is most important. So here you can do, doing the apical resection, and then you can do it. So how smoothly it is coming out, because I think the cautery has really improved the whole resection practice. And here you can see the capsule, and then you can divide it. So one of the thing is, of course, um, um, how much saline you are using, the anesthetist should know, and then how much is the output is coming out, so that he can adjust the what is the blood pressure, what is a bradycardia or something. He can adjust that with the diuretic or giving fluid. Always replaced by saline, because then there is always a chance that there may be a hyponatremia during the procedure. So it's a combined teamwork, and once you have a same team, the anesthetist and you are working together. He keeps a eye on that. Now, once you have almost cleared that completely, what I do is I do now vaporization. Now, advantage of vaporization is not only hemostasis, but then whatever that tissue left before the, I mean, or surrounding the capsule, I vaporize that. So what happens? I less chance of perforation, and then I make it smooth. When if it is smooth, less chance of anything bulging out, then chances of post-operative symptoms of frequency and things are much less. So here, as I find it, so that this, like this tag, I just vaporize it, so it becomes a smooth now. Capsule becomes a smooth. So all that area, I'll go around and then make sure that there is a hemostasis, and then all the tissue which is there. I have already calculated on ultrasound how much is the tissue, how the prostate is looking. So I'm fully aware of that, and then I will do the vaporization accordingly. And so let me go a little further. Now here, once you have almost finished the um, vaporization and your cavity is good, you are happy that almost all the tissue is out and that's good cavity. Almost if you remove the 85% of the gland, you will have non-obstructive prostate remnant. Because so now this is the veru and this is the bladder neck, and then here is completely done it. So what I do last is um, look at this is one, and then I look at the ureter, and then make sure there is oil hemostasis all around, you know. And the last part which I do, now there's some tissue tag is there, so I will vaporize that, and then look at the ureteric opening, and then what I do is bladder neck, lateral incision. So so this is incision which is making a deep, so that will prevent any bladder neck stenosis. If you use a amount of churning or cautery, if you use it minimum, then there would not be a much contraction. On bilaterally, we will do that. We will make a small incision. Now you can see that cavity, and then the hemostasis is done, whole cavity is done. So here at the end of the procedure, I will put a suprapubic small tube and the two-way catheter, and I do irrigation afterward. So this was the pre-resection and this was the post-resection. And the most important, remember one thing is, once you remove the transistor zone, peripheral zone will expand. So radiologist afterward will say prostate size is same. The patient will come running and say, Sahib, you are not removed my prostate. And actually, because you explain to them before, because the transistor zone enlarged, that is removed. But what you see is a channel cavity, and that is the most important for flow. But still, the proof would be your uroflow. And here you can have a good peak, and then you can say that your flow is better, your symptoms are better, you are better. So that is all right. And the prevention of incontinence, I told you about these 2-3 zones, which is important. And last slide is median lobe. In median lobe, what you cannot do the 12 o'clock. So here I just showing you, this is a Marburger's loop, and this loop is wide. It is of course a unipolar, but here's a wide loop, and you can remove the more tissue in a one cut. So it reduces the time taken. Here is the bleeding you can control. Now, bleeding is always at certain point, which you must control. Any bleeding at 11 o'clock, 5 o'clock, or 7 o'clock, 1 o'clock, you must control it. And then whatever sputter, whatever bleeding you see at the capsule, you must control it. In tissue, you may see the bleeding, but then you wait. Like here, you're seeing the bleeding. But you don't want to cauterize here in the tissue because it will retract, and then you will not see it. But once you come near the capsule, you must this is still artery. Now I have cut it, and now you can see the capsule is seen on the distant, and then after this I will cauterize the bleeding. So always cauterize the bleeder at the capsule. You will find. Now once your median lobe is over, your flow will be good, and you will be able to you have a good flow. Then your vision is better. Now, if your vision is better, you can do the good resection. So this is the how you can remove the median lobe first whenever you have a large thing, right? And sometime while doing, in earlier we used to see the perforation because that time our experience was less. The idea was don't directly go to the capsule, but go by the side and coagulate by the side or press it. So the vessels which is feeding into perforation will stop. Always make sure that there is a water absorption is going to be there. You make sure that it is controlled. So you must, if it is identify and control, less chance of bleeding in there. And this is there is no prostate here, but he has got an obstruction. So what we do, we look at the ureteric opening, and then here is the ureteric opening is seen. This is the ureteric opening. So lateral to ureteric opening, we make a cut. So I'll show you on the one side. And here you make a deep cut, and then you're making a deep cut in the fibrous tissue, because such is a fibrous gland, because there's hardly any tissue there. And you make a deep cut, and then you divide that. Similarly, you do it on the other side, and then again lateral to the ureteric opening, and then you can divide that. So whole floor will go down. Now, initially you have seen it when you were entered, did a cystoscopy, you could not see the bladder. Now you can see the bladder. So that is how you do the bladder neck to do it. Now at the end of the exit seat is where to put a catheter. Never put a catheter in the capsule, into the fossa. Patient will have lots of pain. You might be able to control the venous bleeding, but that if the bleeding, you control it. Otherwise, this is the venous bleeding, no arterial bleeding. You put a balloon into the bladder, increase the blooding to 30 to 35, and then pull it. The whole prostate is collapsed because you have removed the transitional zone, and the bleeding will stop, and that will be fine. So TURP syndrome, I already told you that if you see a bradycardia, give a Lasix, make sure you use a saline, and then post-operatively you do a sodium, serum sodium, and then replace the sodium. Thank you very much.